Welcome to part 2 of the Anesthesia Knowledge Test, Commonly Missed Items Review. This topic here is naloxone dosing. Thank goodness we don't use naloxone too often in the operating room. We probably most commonly will use it in the PACU if patients should become re-narcotized after or overly narcotized after using opioid intra-op. So it is very important to know how to use this drug and to be familiar with its properties. It is a pure mu, kappa, and delta agonist. IV dosing is generally 20 to 40 micrograms with an onset in 1 to 2 minutes and a duration of only about 1 hour. Now, this is a bit dangerous, and after giving naloxone, we can't simply walk away from the patient because, especially if they're treating longer-acting opioids, patients can become re-narcotized after that 1 hour when the naloxone starts to wear off. If we're giving naloxone IM, the standard dose is 0.4 milligrams, which in our vials is 1 cc. It also has various side effects, so pain, arrhythmias, hypertension, and perhaps the most feared is pulmonary edema that can come from naloxone. All right, our next topic here is rocuronium elimination. So this is the chemical structure over to the right of rocuronium. As you can see, it's a very large molecule. It is primarily eliminated unchanged by the liver in bile. It's less eliminated in the urine. It's about a 70-30 sort of ratio. But it is important to know that the primary way that rocuronium is eliminated is through the liver in bile. So patients with renal failure can be given rocuronium. The speed at which it's eliminated may be mildly reduced, but you absolutely can use rocuronium in folks with renal failure because it is mostly eliminated unchanged in the liver, or by the liver rather. All right, this topic is unique characteristics of desflurane. Over on the right-hand side, we have the chemical structure of desflurane. It's a fluorinated hydrocarbon with 6 fluoride ions. It has the lowest blood gas solubility, and this results in rapid induction and rapid elimination. It is the least potent of all of the volatile anesthetics. And what this means is that it requires the highest concentration for its clinical effect. 1 mac of desflurane is over 6%, whereas 1 mac of the others is around 1 and 2%, the others being isoflurane and sevoflurane. It has an incredibly pungent odor. And if you've ever smelled desflurane, you definitely know what we're talking about. This pungency nature can cause laryngospasm, bronchospasm. It can also cause breath holding, especially in children. Rapid increases in concentration can often lead to rapid increases in heart rate in desflurane. Every once in a while, if a patient is tachycardic initially at the onset of desflurane anesthesia, this can be, we can see this rise in heart rate. There's also a greater formation of carbon monoxide when it interacts with the absorbents. Desflurane tends to be the most expensive of all of the inhaled anesthetics. This is due not only to the anesthetic itself, but also because a special heated vaporizer is necessary due to its very, very high partial pressure, causing it to evaporate very, very quickly and become very cold. That's why the vaporizer needs to be heated. There's also a significantly worse environmental impact with desflurane. It breaks down very, very slowly in the environment and is a very, very powerful greenhouse gas. All right, our next topic here is end-tidal CO2 measurement, more specifically comparing end-tidal CO2 versus arterial PCO2. So as we know, normal arterial PCO2 tension is about 40 millimeters of mercury. As we can see over on the image over to the right there. And normal end-tidal CO2 is about 2 to 4 millimeters of mercury lower than our PCO2. And the reason for this is dead space. Now, there are different types of dead space, and dead space comes from different areas, namely apparatus, which includes the endotracheal tube all the way up to the Y piece. Anatomic dead space includes the trachea and the bronchioles that do not have alveoli attached, where there actually normally no gas exchange takes place. And then there's also alveolar dead space, which includes alveoli where there's ventilation but no perfusion, or atelectasis. Now, this difference in end-tidal CO2 is mostly due to alveolar dead space, because the other sources of dead space are washed out through the respiratory cycle. But the alveolar dead space we are unable to overcome throughout the respiratory cycle, and thus we see this difference. Okay, our next topic here is hepatic oxygen supply. There's a nice short article on open anesthesia that summarizes this topic really nicely, so if interested in, or you're still a bit confused about this topic, I would suggest reading this short blurb. So your blood supply to the liver comes from two sources. The portal vein carries the majority of the blood, about 75%, and the hepatic artery carries the minority of the blood, about 25%. Now, your oxygen supply is about 50-50 from these two sources. The portal vein brings half, and the hepatic artery brings half. Now, regulation of this blood flow is a bit complicated. So since the portal vein flow comes from the splanchnic circulation, and the splanchnic circulation varies based on autonomics, based on eating a big meal, and other metabolites and such, there needs to be a system to regulate flow through the liver to ensure that the liver is adequately oxygenated. So this comes with the hepatic artery buffer system. So as portal vein flow decreases, hepatic artery flow needs to increase. This is done by adenosine, and the hepatic artery is then dilated. The opposite is true when there's adequate flow through the portal vein. The hepatic artery constricts, also due to changes in adenosine. All right, blood gas interpretation is the next topic that came up on the SCORE report. Again, open anesthesia I love. It has a really, really nice summary of acid-base interpretation of blood gases. It's a very, very big topic, but some commonly tested things, which I'll go over here, are the different types of analysis of blood gases. So there are two types, alpha stat and pH stat. Alpha stat is the type that's generally used for adult patients, and what we commonly use without even knowing it in the main operating room. This is a non-temperature corrected method, which means that our sample is heated up to 37 degrees, analyzed, and then nothing else is done to the patient. pH stat is a temperature corrected system where the sample is made to have a pH of 7.4, and we do this by adding CO2 to the patient. That isn't necessarily done in adult patients. You can see increased cerebral blood flow, increased rates of embolic disease and things like that. pH stat is a method that's commonly used in pediatrics, but the common testing points about alpha stat are that it's non-temperature corrected and you heat the sample to 37 degrees. Again, please go take a peek at that open anesthesia blurb. Okay, so our next topic here is the law of Laplace. Something that comes up quite a bit because our clinical relation is that this is how alveoli are stented open by surfactant. So the law of Laplace says that the tension in a sphere is calculated by pressure times radius divided by 2. So the larger the radius, the higher the tension is, and the more surfactant is necessary to keep this open, the higher the surface tension there is. So this is something that's important to memorize, the equation, of course, and then it's important to understand the clinical relevance. All right, this topic comes up over and over and over and over again, saturation and PaO2 relationship. This is a curve that you'll see forever and ever and ever, the oxyhemoglobin dissociation curve. So saturation and oxygen concentration is a non-linear relationship, as you can see over to the right. Where you fall along this curve depends on many factors. It depends on 2,3-DPG, depends on pH, depends on temperature, and it depends on CO2. Above 90 millimeters of mercury, where we can see up at the top of this curve, it's nearly flat. I don't think it quite even, this curve, this image does it justice. And then below 90%, it sharply falls off, so that as you drop from 60 to 50 to 40 millimeters of mercury of oxygen in the blood, the saturation drops dramatically. So please do yourselves a favor, really study and internalize this oxyhemoglobin dissociation curve. Think about the different factors that cause it to shift left and to shift right, because you will absolutely see questions pretty much on every test you'll ever take from now until the end of time. All right, our next topic here is succinylcholine-induced bradycardia. We have the chemical structure of Sux over on the right, and as you can see, it's really two acetylcholine molecules pasted together. One of the issues that you can get with repeated succinylcholine administration, or sometimes Sux administration in children, is bradycardia. How this happens is through nicotinic activation. Since we are talking about acetylcholine here, you can get some nicotinic side effects from succinylcholine, namely bradycardia. And as we said, it's most common in children or repeated administration. We don't often do this succinylcholine drips. It was more of a common thing that was done in the past prior to Sugammadex and such. All right, this topic goes over the Aldrete score. So this is a very important part of your PACU rotation. How do we know that people are ready to leave the PACU? A lot of us just sort of go by and say, yep, that patient looks good enough, but in our minds, whether we know it or not, we're actually going through this scoring system to make sure that folks going home and up to the floors can do so safely. Again, please take a look at this open anesthesia article here. The Aldrete score is out of 10 points. There are 5 different criteria, 2 points apiece. And it's common to be tested on these different criteria. So it's A, B, C, C, O. Activity, so if you can move all 4 extremities to command, that gives you 2 points. Breathing, if you're able to breathe deeply and cough, you get 2 points for breathing. Circulation, your blood pressure should be within 20% of your pre-anesthetic levels. That's why the nurses will call you and ask what their pre-op blood pressure was. They're trying to get that blood pressure as close as possible to their pre-op blood pressure. Consciousness, so if a patient is subjectively fully awake, they get 2 points, and then O2 saturation greater than 92% on room air gets your your full points for that. In order to be discharged, you require a score of 9 out of 10. Whether we know that we're doing this or not, this is what we look at when discharging patients from the PACU. All right, our next topic here is laryngospasm treatment. Laryngospasm is something that's very, very feared, mostly in children, but also with adults. And knowing how to break a laryngospasm is incredibly important to the general practice of anesthesia. So if you note that you're not moving air very well after extubation or before extubation, you should always ensure that you're ventilating with 100% oxygen. You should hold the CPAP, the mask to CPAP with an adequate seal, and you should give a vigorous jaw thrust. This in and of itself can oftentimes break a laryngospasm, but if still that doesn't work, you should consider deepening your anesthetic, either with an inhalational agent if you're moving any air at all, or with an IV agent such as propofol. If you are unable to ventilate and you are starting to become hypoxic, you can break the spasm with a very small dose of either succinylcholine, which acts rapidly, or with another neuromuscular blocker. Atropine is listed there as a treatment because with hypoxemia comes bradycardia. So especially important in children because cardiac output is dependent on heart rate. Atropine is a very, very important part of the treatment of laryngospasm. Also, if we're going to give sucks in children, just as we discussed a couple of minutes ago, it's important to ensure that you avoid bradycardia. All right, our next topic here is postoperative atrial fibrillation. So it's well described that atrial fibrillation is definitely a risk of going through surgery. In non-cardiac surgery, our risk of this for all comers is somewhere between 0.4% to about 12%, depending on the sources that you read. And this atrial fibrillation comes from a lot of different places. So if you look over to the diagram on the right, it often originates with pain of surgery. This pain leads to increased sympathetic outflow, which can cause atrial fibrillation in and of itself, increased sympathetics. Other factors that are common during surgery can contribute to this, so being cold, hypoglycemia, being anemic, being hypoxic. This can often sensitize the myocardium and make atrial fibrillation more common. Inflammation related to surgery in general can also kick this off and contribute. And it's very complex in how atrial fibrillation comes about, but it's all of these definitely contribute to the relatively high rate of AFib after surgery. All right, this topic here is the ASA physical classification system. So, we talk about this and think about this just about every day, but actually internalizing what each of these numbers means is something that we don't often do. The basic exam will generally have at least one question where they describe a patient to you and say, what is the ASA classification status? And so it's important to really understand what each of these things mean. So as we all know, ASA1 is a normal, healthy patient, no unhealthy habits, no smoking, minimal alcohol use, the type of person that you, sort of visualize as a health nut who is completely healthy. Most people around are ASA2s. This indicates mild systemic disease. Folks who smoke, people who drink more than very, very rarely, folks who are pregnant, folks who are mildly obese, people with well-controlled illnesses. I would hope that I am squarely an ASA2 with my type 1 diabetes. So I would say most people are ASA2s. ASA3s are folks who have whose mild disease has progressed to a more severe systemic disease, and there may or may not be functional limitations. So, poorly controlled diabetes, poorly controlled hypertension, morbid obesity. So all of the patients coming in, or the vast majority of them coming in for sleeves, gastric sleeves, are ASA3 patients, although a lot of times we don't mark them as such. Folks who have any sort of substance abuse, folks who have smoked to the point of lung disease, people with implantable devices, end-stage renal disease are ASA3 folks, and people who have history of stroke-related illness, any sort of coronary artery disease, ASA3s. ASA4s are patients who have severe systemic disease, but their systemic disease has progressed to the point where it's a constant threat to their life. So that includes recent MI, recent stroke, folks who have severe valve disease that's causing them ongoing symptoms, folks who have severely reduced ejection fraction, people who are whose kidney disease is not being treated by dialysis, so that actually is a constant threat to life, things of that nature. An ASA5 patient is somebody who will die if they do not immediately go for surgery. And usually that also is within, folks will say within 24 hours they're expected to die. So these are, massive traumas that come in, ruptured aneurysms, bleeds, things of that nature. ASA6, don't forget about that. That's a patient who has been declared brain dead and who is donating their organs. Okay, this topic is contraindications to spinal anesthesia, often tested and very clinically relevant. Contraindications are always broken into absolute and relative contraindications. Absolute contraindications to spinal or any regional technique, the first one on the list is always patient refusal. In fact, I had a patient the other day who would have benefited greatly from a block. They staunchly refused despite understanding all of the risks and benefits, and so that is the number one contraindication. If a patient is clinically in shock, the hypotension that naturally comes from the sympathetic blockade of a spinal makes this an absolute contraindication. And also infection at the site where you're planning on placing the injection is also an absolute contraindication, as this would introduce infectious material to the meninges. Relative contraindications are coagulopathies, varying degrees, spine disorders, including post-surgical patients who have implanted material right in the area of the injection. Increased intracranial pressure is a relative contraindication for fear of herniation. Patients who are uncooperative are often very challenging to place spinals in, and then also the last one is an important point. Folks with stenotic valve disease, whether the mitral valve or the aortic valve, have a relative contraindication to neuraxial anesthesia, especially spinal. The reason for this is that with the fixed obstruction, the patient can't overcome the hypotension that comes with the spinal by increasing their cardiac output. So folks with severe stenotic disease often are not great candidates for spinals. All right, this topic is factors affecting spread of epidurals. There's a nice article here from Anesthesiology that describes this in a little bit more detail, but in general, there are a few major factors, a few minor factors, and then a few factors that do play a role but are minimally relevant. So major factors include the site of injection of an epidural and the dose slash volume. In this table it says dose, volume is also included as well. Of course, with a site of injection, the spread is going to be centered around that site of injection, both in a cephalad and caudad direction. Dose is also important, although possibly even more relevant is volume. Epidurals are volume-based blocks, so increasing the volume while maintaining the same dose will increase the spread. Increasing the dose while maintaining the same volume will also increase the spread as well. Minor factors, height, of course, will have less spread. If you were to give me an epidural at 6'5", I would need a much higher volume to have the same spread as somebody much shorter. Pregnancy causes a greater spread of epidural medication due to the smaller epidural space. Minimally relevant factors include speed of injection. So some folks have shown that a faster rate of injection will spread the epidural block further, although it's a very small factor. Also, direction of the needle has been shown to very minimally affect the rate of epidural spread. Obviously, the needle directed in the direction of the spread will it will go that way. Our next topic here is intravascular injection of test dose. So for those of you who haven't placed a lot of epidurals or who haven't been up on OB yet, after an epidural catheter is placed, we always will give a test dose through the epidural catheter. What this is 3 cc's of 1.5% lidocaine plus epinephrine in a concentration of 1 to 200,000, which in 3 cc's, as we've discussed earlier, is 15 micrograms. And this is used to prove two things. First, it's used to prove that the catheter is not intrathecal, and two, it's used to prove that the catheter is not intravascular. Intravascular placement of catheters is not uncommon. The epidural space has many veins, especially in pregnancy. They become engorged, and the catheters can slip into those vessels every once in a while. So when you give this test dose, if the catheter is intrathecal, when you aspirate, you may see CSF in the catheter. When you inject the test dose, you'll get very heavy legs and hypotension almost immediately, similar to placing a spinal. And if the catheter is intravascular, you will see an increase in systolic blood pressure and an increase in heart rate. The usual values are, assuming that patients aren't on beta blockers, usual values are an increase in heart rate greater than 20 beats per minute and a systolic blood pressure increase in greater than 15 millimeters of mercury within the first minute of injection. Okay, our last topic here is spread of intrathecal injection. Now, we've already talked about the spread of epidural injections, and you'll see that there are different factors when you're talking about the spread of intrathecal injections. So the first and most important factor is the porosity of the solution that you're using. And what this means is the density of the solution when you compare it to CSF. Now, these medications are composed of either local plus dextrose, that gives you a hyperbaric solution, or local plus sterile water, that gives you a hypobaric solution. Isobaric means that it's approximately, the density is approximately equal to CSF, and the block results about at the level where the medication is injected. Hyperbaric solutions will follow gravity, and hypobaric solutions will go against gravity. So this is where patient position becomes very important. Most of the solutions that we use, probably at least 80 or 90%, are hyperbaric solutions. So patient position is important because the solution will follow gravity. That is, if you put a patient head up, it will go in a caudad sort of direction. If you place a patient head down, it will go in a cranial sort of direction. The spinal curvature is also very important as to the spread. The kyphosis in the mid-thoracic spine will prevent the medication from traveling too far toward the cervical region when the patient is supine. That's useful for spinals during C-sections. The goal is to get a T4 level, so this works out quite nicely. There are some other factors that are less relevant. Dose and volume are less a factor in spinals as compared to epidurals. Temperature, age, and pregnancy all are minor factors that affect spread of intrathecal injections. Very little or no effect is weight, height, gender. Barbotage is a technique where you inject the medication, aspirate CSF, inject again, aspirate CSF. That is also has very, very, very minimal effect. Okay, everybody, thanks for watching. I encourage everybody to study really hard, create a study plan, talk to me if you need some help, and we'll do more of these in the future. Good luck.